So the title of my presentation is the Assessment of Outpatient Clinic Scheduling Model. This is work that was done by two colleagues of mine, Mark Lawley and Yan Lee, while they were both at Purdue University. Now, Mark is with me at Texas A&M University, and Yan is at the New York Academy of Medicine. So for today's agenda, I'm going to kind of give you an introduction to the hospital, which I've already done, and we'll talk about specifically why we chose to use AnyLogic. I'll show you the model that we have. I'm a programmer by nature, so we'll look at a little bit of the details in the model. And then I'll show you some of the results and how the hospital systems have been able to use that. And we'll look at we didn't stop with this model, we're doing some new things with it now, and I'll talk a little bit about that at the end. So this is the hospital system I was describing. And like I mentioned, our model is working on an outpatient clinic. Outpatient means that the patient comes in and gets seen and leaves the same day. And so this hospital system, as you can see here, sees over 2.6 million outpatient appointments per year. So this is a very important problem to them to understand how to schedule and make capacity decisions. And so they had asked us to work on this problem. So here's a description of what they wanted from us. They asked us to create a model that was aiming to do a predict their scheduling system and see how patients come into their clinic based on one important criteria, and that's the fact that they have a large problem with no-shows. So no-shows mean that patients don't show up for their appointments that are already scheduled. And one of the clinics that we're working with now is actually in a very low-income area, and more than 30% of their appointments are no-shows. And so they want to know how to increase the efficiency and the utilization of the facility, while also keeping down overtime and keeping waiting times to a minimum for the patients. So some of the limitations that were imposed for this model was to think about the physician's schedule. So we worked, for developing the model you'll see today, we worked with the schedule of the physician, and so they wanted to specify the number of hours they would be working. They wanted to specify how many patients they wanted to see a day, while also imposing some restrictions on some of the more high-maintenance patients, which would be those that were sick that day versus those that were coming in for a recheck. And then also there were some, for this particular clinic, they classified patients in two different tiers, and we'll talk about that in a moment. So this is kind of an overview of what we're aiming to do. Now, why did we choose AnyLogic for this approach? I've worked with several different softwares, simulation softwares, and we really like AnyLogic because of the functionality that it has, as well as the user-friendliness. We knew we could take a systematic approach to this problem. We knew it was going to be easy to learn for other people, even the physicians, to look at the nice engaging interfaces that you can create. And it also allows a lot of versatility for expansion later on, because you can do, right now this model is discrete event, but we can expand it to include other components such as agent-based as well. So this is why our team chose AnyLogic. So here is an overview of some of the model components. The first one is a home screen. The input screen is the most important component for the physician that's going to be using our model. They want to specify their hours, the expectation of no-show probabilities for their clinic, the patient mix that they're expecting. We even look at arrival rates, and so you'll see some of that in a moment as well. And then we have the model, so you can actually go to the model screen, see the source nodes, the queues, and so forth, and we'll do that today as well. And then we have the output screen that shows the model results and some of the important performance measures. Many of those are coming in from the physician's perspective, and so we'll see that too. So here is the interface that we have. So most of the information on the left is going to be like known parameters for the clinic. For example, on your top left, you see appointment request. So we break that into 3 stages. So we assume, for example, in this slide, between 8 to 11, we can have 2 appointment requests per hour, and we do that in 3 different phases. Next to that on the right, you see the no-show rate, which can be 10, 20, 30%. And then further to the right is the sick patients. We're going to go to the code. Because this is a discrete event, you can see a very clear pattern of how patients are flowing through the system, so we'll look at that. One of the things I will say is that while we have the physician in this clinic, some patients often get diverted to other peer units or urgent care or even a nurse practitioner. So we have taken into account how many get diverted to a different path. And so that's what we're doing there with the sick patients, is how many can see the physician on the same day versus how many get diverted to a nurse practitioner. And then on your bottom left in the larger box, we have some patient characteristics. So at this clinic, they have sick patients that come in and are requesting same-day appointments. And then for after that, they have two tiers. So tier one are patients that actually have some type of insurance that has a contract with the hospital, and thus they're given some type of priority in the scheduling process. And so among the tier one patients, you can have a new patient as well as those that are doing a recheck or a follow-up appointment. And then same thing with the tier two, you've got new and recheck, but they're the ones that do not have an ongoing contract with the hospital. So overall, that gives us 5 classifications of patients. And from there, we know the patient mix among those for different seasonal times of the year. And then another important factor is the treatment time. So often you'll see the newer patients have longer appointment times than the recheck patients. So we have different appointment times for each of our patient classifications. And so all of the things I just described to you are more of the known information for the model. On the far bottom right, you see the MD, which is medical doctor, so that's the physician's working schedule. And so here's what the physician was primarily interested in playing with. There's 4 columns there. On the left, you've got, and that's 5 days a week, Monday through Friday. On the left, the first of the 4 columns, the physician is putting in the number of hours that they're working each of those weekdays. In the second column, this is where the patient is specifying how many patients they want to see at the clinic, excluding the sick. So this is kind of setting their overall capacity for the day. And then what they want to do in the far right 2 columns is limit the number of sick and new patients that they have. And so they're going to play with these capacity input parameters here and look at different outputs from our simulation to see which one of those help them increase their utilization, but also reduce the overtime for the physician and reduce the waiting time for the patients. So that's our model input. So that's one of the 4, and this is our model output. Here I just want to kind of give you an idea of what we're printing out, and we'll talk about a little bit more of the results later on. So in the top left, where you have that bar graph there, that's telling us the total among the 5 patient types that we have, so sick, tier 1, tier 2, new, and recheck. We know how many patients we see of each type. Below that, in the box here without any graphs, this is showing the daily capacity. Now, the daily capacity is actually not necessarily what the physician put into the model. It takes that information and accounts for the processing times for each patient, and then accounting for that, then based on the different types of patients, then we can see how many total we can see for the day. And then finally, in the upper right, you've got 4 graphs that are showing us the wait time for the patients. And then in the lower right, this is one of the more important pieces of information the physician's getting out of it personally, and that's how much they're utilized in the facility as well as the overtime that they have to spend in the clinic each day. And then the final, the pie graph on the bottom right tells us the mix of patients, of how the sick patients were split up among the physician, the nurse practitioner, and then the peer or urgent care facilities. And so we'll look at some results later. So this is where I plan to run the model. And we're not going to do that. We're going to keep looking at screenshots. But I will tell you that we do have, if you're interested in learning more about this model and seeing how it runs, it is publicly available on the runthemodel.com. So we have it up there, and so you're able to go look at that, and you can talk to me as well. So here's the code, and as I mentioned earlier, I'm a programmer by nature, and so this is the part that I enjoy the most. So I apologize for those of you that don't enjoy this, but we're going to talk about it just a little bit, mostly because it's going to show you the flow of what our model is doing. So keep in mind this is discrete event model, and so you can see that pretty well here in the top. So if you look, let me see if my pointer will work. So here we have a source node that's just generating our patient arrivals. When you move to the second column, here we have a branch that's kind of creating our patient mixes. So on the very top, this is where our sick patients are going. So there's some probability that they're sick and they're going to be seen the same day. The sick patients have their own path across the top because we don't, since they're sick and they're being seen the same day, we don't have to worry about no-shows for them. They're already there in the clinic. The other patients that are calling in and requesting an appointment are handled on the bottom part of this flow diagram. And so they're split up here. You see the 4 branches because that's creating the 4 remaining types of patients, which are Tier 1, Tier 2, new, and recheck patients. So once the patient type is assigned, then their schedule is created, given priority to the Tier 1 patients, more so than the Tier 2 patients. For the time being, in this version of the model that I have here today, based on their prioritization, they're still being scheduled mostly first come, first serve, and I'll talk about some of the ways that we're extending that in a little bit. And then once the patients are scheduled, they're at home, they're waiting for the day, so they're in a queue here. And then on the day of their actual appointment, they arrive to the clinic. So then once they arrive to the clinic, they have to check in, which is the box that you'll see around here. And then from there, kind of the wider box, I think somewhere around here, I'm trying to see from the side. This is where we account for the no-show probability. So as much as 10, 20, 30% of the patients are no-shows, and we capture, we have some sync nodes there that are telling us, computing that data on how many patients did not show up for the appointment. And then the remaining half of the diagram on the far right, you've got the physician down here and the nurse up here. And so they're seeing some of the patients, and if you've followed along with me so far, you can also see how they got split off to either the patient, to either the physician or the nurse. And then finally on the far right, we have our sync nodes that are also computing how many patients by type were seen for the physician. One thing I'll also mention somewhere along the top here, the patients that were diverted to urgent care or to a peer facility, we don't take them any further in the model. So like if they were same day sick, then some percentage gets sent somewhere else and we don't account for them anymore. So we have a percentage that does get sent off to a peer facility, some patients that get seen by the nurse. The nurse patients are only the same day sick patients. Any appointments that were actually scheduled in the system for some later date all follow the path to the physician, and so those patients actually see the physician. All of this down here at the bottom is just where the programmer set up our variables and parameters and other things that you don't need to worry about for today. Okay. So when we run the model, we can run it, we'll be adjusting mainly the physician's schedule, and we'll be looking to see to see how we can change those capacities for each of the different types of patient to impact some of the output performance measures that we have here. So if you look here on the top left, I know it's a little hard to see, but this taller orange bar is the number of sick patients that are seen by the physician. So the physician does, the sick patients are on the left. So then we see mostly those newer patients that are coming in. And then the physician, as I mentioned earlier, is also mainly looking at this down here. And so for this model, when you look at the utilization of the physician, along the bottom here, you have that from 0 to 1. So most of it's over here near 1, meaning on average, they're almost 100% utilized. The tall red bar is actually showing the average, and the blue is showing the distribution. And then for on the far right, the physician, their overtime is shown per day as well. And then you can finally also see the patient mix there. So why is this significant? Well, it allows the physician to test different theories of, I want to see 20 patients a day, but I want to only see, I want to limit that to 4 sick patients and 4 new patients a day. And we'll see what those policy decisions, how they're impacting the utilization and overtime in the clinic. By using AnyLogic, we're able to develop the simulation model and offer a low-risk cost way to apply these different theoretical policies and see how they perform in the clinic setting. And we can also help prepare, even thinking beyond that, we can prepare for situations in which we have a maximum capacity in the facility. So some of the benefits that we achieved is we can look at these capacity decisions. We can see how long on average each patient even waits in the clinic if we're interested in performing some of our patient-centered outcomes, which have been are heavily emphasized with the new Affordable Care Act. Everything is looking at the patient's perspective now, so that's also very important, and so we're doing that in our model as well. We also want to see how many of the sick patients are actually being able to be seen on the same day when those requests come through. And then also just on a long term looking at the physician utilization as well as their overtime. And so as an update to all of this, unfortunately, after Mark and Yan left Purdue, Indiana University Health Arnett was not as interested in being able to use our model. So what we've done is we've taken it with us to Texas, and we're working with the Diabetes Health and Wellness Institute, which is DHWI. These kind of things are pretty common in academia. You get a partner, and sometimes you just have to adjust and move on. So we're working with the DHWI, and we have 2 graduate students as well as 1 senior design team composed of 4 undergraduate students that are extending this model. They're looking at new scheduling policies. As I mentioned earlier, this is the clinic that is in a heavily underserved and impoverished area. Because of those types of situations, patients not keeping phone numbers up to date, their no-show rate is very high, 30-40%. And so they're looking at new scheduling policies such as doing double booking through different parts of the day to see if they can improve their utilization. And so the senior design team's working on that now, and we plan to implement it in January 2016. So these are my references. The first one is the RUN model that we have, and then there's also information on the clinic that we've worked with. And that concludes my presentation. So thank you for the invite, Renee. Thank you for your attention, and I appreciate being here. Okay, thanks. I'm sorry? Yes, the new partner that we have at the clinic, it's very small. There's only 1 physician there, and she works with us on a weekly basis to see what we're doing, and she's very interested in implementing this at the when the senior design team finishes at the end of the year.
So when you moved from Indiana to the hospital in Texas, it looks like the demographics was similar, so you were able to use the same model.
Yes.
How robust is the model if you can just change it to another demographics, and maybe many other hospitals might be able to use it, especially because in the input screen you have a lot of those variables which you can adjust.
Yes, and so that's one of the reasons we came forward with this now, is to share what we've done. It is very robust, and we're happy to share what we've done with any other clinic that would like to, or we can modify it for you or not, or you can have it yourself. And so, yeah, we think it's very robust, and that's why we're easily adapting it to the new clinic we're working with. Thank you. All right. Thank you for your attention.